today I'm going to address 5 issues related to the diagnosis and treatment of growth hormone deficiency. I think 4 of the 5 can be labeled as somewhat controversial, and so you be the judge of that. So here are my brief disclosures. And so the objectives of today's presentation are to review the appropriate clinical setting for both screening for growth hormone deficiency as well as growth hormone stimulation testing. We will discuss the performance and the pitfalls of growth hormone deficiency screening tests and growth hormone stimulation testing. And for the latter, more specifically, discuss the use of sex steroid hormone priming as part of the diagnostic testing. And finally, the last 10-15 minutes, we will discuss some of the controversies that are related to the therapy of growth hormone deficiency, including dose adjustments based on IGF-1 measurements, therefore IGF-1 titration, as well as the management of patients with a suboptimal response to treatment with growth hormone. So the investigation of a patient with a potential defect of the growth hormone IGF-1 growth plate axis needs to begin, like with any potential clinical dilemma in pediatrics and in medicine, with a carefully obtained history, a complete review systems, and a well-executed clinical exam. Specifically, when we think about the potential of growth hormone deficiency being at play, the birth history will need to focus on particular aspects such as the possibility of consanguinity. We need to obtain information not only on parental heights, but also the heights of grandparents, aunts, uncles, and other first-degree relatives of the patient. And I cannot underscore enough the importance of trying to obtain a good impression of the patient's prior growth pattern. So I'm showing you a growth curve here of one of my patients, to whom I will come back later in the talk, where you can see a very gradual deceleration or deflection from his target height curve. And sometimes with electronic health records and also with patients being seen by multiple providers, it's not always straightforward to get a nice growth curve, but it is so essential in helping with the diagnosis of growth hormone deficiency to be able to have that information, as well as detailed nutritional assessment. As we all know, in so many cases, there is also a factor of nutrition that plays a role in poor growth, even if there's an underlying diagnosis at play. So for the physical exam, we obviously focus on oxology, and we should not forget to try to get an impression of the possibility that there may be some disproportionality at play. And of course, try to pick up on any potential subtle dysmorphic features will be helpful in making the diagnosis and steering us in one way or the other. With regards to the screening tests, many physicians and many pediatric endocrinologists will adhere to obtaining general investigations to sort of rule out organ system disease, although I tend to be in favor of a more focused search for an etiology, more focused investigation based perhaps on abnormalities that were found on exam or that were present in the history. There's no question that it's important to obtain thyroid function testing early in the workup, because hypothyroidism needs to be ruled out in any patient with short stature and potentially growth failure. One of the tests that we always perform in the workup of growth hormone deficiency is a bone age X-ray to get an impression about the patient's skeletal maturation. And I want to say a couple of words about bone age assessment related to the workup of growth hormone deficiency. skeletal age may not be delayed in recently acquired growth hormone deficiency. There may not have been enough time for the bone age to be delayed. Bone age assessment is also less reliable in very young children because of the great variability there exists in the appearance of the ossification centers. It's also less helpful in obese growth hormone deficient children. And finally, bone age assessment may help us also in identifying signs of skeletal dysplasia that may be quite subtle. So nowadays, there are also automated methods available to read bone ages on patients. One of the things that is connected to automated methods is that it may improve the consistency in the interpretation, as we all know that bone age interpretation is quite subjective. So that's a positive thing. On the flip side, automated methods sort of prevent us from picking up subtle signs of skeletal dysplasia. So one should keep that in mind. So the first issue to raise may not be truly controversial, but I think it's important to bring up, and that is we should at all costs try to avoid inadequate evaluation of certain subgroups of children with short stature. And I want to point out 3 subgroups. First of all, short stature in girls is often under-investigated, and there is absolutely no reason why the threshold for evaluation in girls should be any different than in boys. In addition, childhood cancer survivors form a group of patients that are at high risk to experience growth failure. And the diagnosis of growth hormone deficiency may be delayed in such patients because, for example, there could be interference with the development of early puberty, which may sort of attenuate the growth failure you would expect in a childhood cancer survivor who's developing growth hormone deficiency. And finally, although patients with familial short stature are often considered as normal variants of growth, we should make a special effort to not always consider these patients as variants of normal growth. And we should make an effort to get a very detailed oxological family history to potentially look for autosomal dominant inheritance patterns. Familial short stature may be due to immunogenic etiology. And for example, patients who are born small for gestational age who also have microcephaly may have such a cause, as well as patients who have distinct clinical features that are somewhat dysmorphic on exam, such as patients with Noonan syndrome. So not all familial short stature is normal variance. So let's go back to our investigation of a patient who may have a potential growth hormone deficiency. Endocrinologists will start screening with either an IGF-1 and or measurement of an IGF-1 binding protein 3. So let's look a little bit at the use of these peptides as biomarkers in the diagnosis of childhood growth hormone deficiency. IGF-1 has been studied for multiple decades for its potential to screen for growth hormone deficiency. Unlike growth hormone, which is secreted in peaks, mainly overnight, IGF-1 concentrations are quite stable throughout the day. There's little diurnal variation. From the normative curves that you see in this figure, we see that IGF-1 concentration over time are influenced not only by the age and sex, but also by the pubertal status when IGF-1 concentrations peak. Nutrition has an important impact on IGF-1 concentrations, as well as the presence or absence of chronic illnesses. But IGF-1 measurements are also heavily influenced by the assay methodology used. The assays for IGF-1 vary widely from laboratory to laboratory, and it's important that the values from large reference populations are used to interpret the measured IGF-1 concentration on our individual patients. I'd like to point out that IGF-1 concentrations may not be very helpful in very young children because of the significant overlap there exists between the normally low physiologic concentrations of IGF-1 in young patients with the abnormally low concentrations that you encounter with growth hormone deficiency. So let's look at the performance of IGF-1 as a screening test. Summarized on this slide are 12 well-executed studies that looked at the performance and the accuracy of IGF-1 to diagnose growth hormone deficiency. From the column on the right, you can see that peak growth hormone levels to make the diagnosis of growth hormone deficiency fall in a certain range. But the cutoff of IGF-1 that was used in all these studies was quite stable. It was either less than 5, less than the 5th percentile, or below -2 standard deviations. So the mean sensitivity of IGF-1 for all these studies is 71%, and the mean specificity 72%. That still means that about a third of patients with growth hormone deficiency have normal IGF-1 concentrations, and just less than a third of patients who are short and normal can still have low IGF-1 concentrations. So in order for IGF-1 to be an efficient screening test, the cutoff needs to be set relatively high at -1 standard deviation. And as one will see from the upcoming slides, IGF-1 still has the better accuracy, about 75% if we take all true positives and true negatives together and divide by the total number tested. So this slide summarizes data from a retrospective cross-sectional study of short and peripubertal children. This is a study that was done to evaluate the discriminatory performance of IGF-1 as assessed either on chronological age, bone age, and pubertal status. From the receiver-operated curves in this figure on the right, you can see that it is actually a similar performance of IGF-1, whether we assess it in function of chronological age of the patient, or the patient's bone age, or their pubertal status. And if you look at the table on the bottom, and we look specifically at the sensitivity of IGF-1 measurements, evaluation of IGF-1 based on chronological age actually has a higher sensitivity than when based on bone age or pubertal status. But if we look at the positive predictive power for the diagnosis of growth hormone deficiency, IGF-1 as assessed by pubertal status has the best positive predictive power. What about some of the other growth hormone dependent peptides that we can measure and their performance in the diagnosis of childhood growth hormone deficiency? IGF-BP3 is one of the more common classic IGF binding proteins. It is part of the ternary complex, and it's the most growth hormone dependent of the binding proteins. As you can see from the normative ranges in both boys and girls, it's also age, sex, and puberty dependent, but it may be somewhat less nutrition dependent than IGF-1. From several studies, we know that the sensitivity for IGF-BP3 is quite low, meaning that many growth hormone deficient patients will still have a normal IGF-BP3 concentration. On the other hand, the specificity of the measurement for IGF-BP3 is quite high, and in all studies it exceeds its sensitivity. That means that the finding of BP3 as a low BP3 in normal children is quite rare. So if you find a low IGF-BP3 concentration in a short child and a child that may have growth failure, that's highly significant. There's also some data that indicate that IGF-BP3 may be somewhat more helpful in younger children, especially in the toddler age and very young children. Sometimes in patients with growth hormone deficiency, you see a discrepancy between the decrease in IGF-1 concentration and the decrease in BP3 concentration. So there seems to be a lack of correlation even if a child is found to have confirmed growth hormone deficiency diagnosis. And that may in part be due to the fact that IGF-BP3 is secreted by different cells in the liver. IGF-1 is secreted by hepatocytes, and IGF-BP3 is secreted by sinusoidal cells. So that may explain why there is this discrepancy. People have also looked at other binding proteins such as IGF-BP2 and acid-label subunit to see if they can be helpful in making the diagnosis of childhood growth hormone deficiency more accurate. Both these peptides have not been reported on their performance in many studies. BP2 for itself is actually inversely related to growth hormone, meaning that if you have growth hormone deficiency, IGF-BP2 concentrations will increase. The ratio of BP2 to IGF-1 seems to be a better indicator for growth hormone deficiency, especially when you look at it in combination with IGF-1 and IGF-BP3. ALS, for its part, which is also nutrition and chronic disease dependent, seems to be lower when checked in childhood onset growth hormone deficiency than in adult onset growth hormone deficiency. But the measurement of ALS does not really contribute that much in the diagnostic assessment of or diagnostic screening for growth hormone deficiency, as its test accuracy is somewhere in between that of IGF-1 and IGF-BP3. So from all these data, we can see that there's no single growth hormone dependent peptide that can be used reliably to diagnose growth hormone deficiency, and that measurement of IGF-1 still provides the best accuracy to diagnose growth hormone deficiency. Now, some of our colleagues will apply MRI, magnetic resonance imaging, relatively early in the workup of a patient who may have growth hormone deficiency, and will use it as a diagnostic test to look for abnormalities of the hypothalamic pituitary axis. It is the imaging method of choice to evaluate the midbrain and the hypothalamic pituitary axis in children, and it may not only provide information about the diagnostic accuracy of growth hormone deficiency, but it may also provide some information regarding the long-term prognosis. We can find some very interesting data from a nice study from Germany that looked at the diagnostic performance of MRI in patients with growth hormone deficiency. A cohort of 110 patients were evaluated for their growth hormone secretion, and 82 patients were identified as having growth hormone deficiency, defined as a growth hormone peak below 5.8 nanogram per ml, and 28 patients were found to have growth hormone sufficiency with a peak above 5.8 nanograms per ml. In 65 of the 82 patients with growth hormone deficiency, a hypothalamic pituitary axis abnormality was detected. This was only found in 13 out of 28 patients in the growth hormone sufficient group. Noted that all patients who had combined pituitary hormone deficiencies were found to have an abnormality on MRI of the HP axis, and the most common finding was an ectopic posterior lobe in 80% of the patients. So the presence of any MRI abnormality as a marker for growth hormone deficiency generated in this study a sensitivity of 79 and a specificity of only 54%, which is really not enough to use this test as a confirmation on its own for growth hormone deficiency. On the other hand, the presence of either an ectopic posterior lobe or the combination of a hypoplastic pituitary stalk and anterior lobe was highly specific and predictive of growth hormone deficiency, and these findings are confirmatory for a growth hormone diagnosis. So Mohammed Magni then reviewed in detail a number of studies that not only looked at the diagnostic accuracy of MRI of the hypothalamic pituitary axis, but also looked at it from a prognostic perspective. And he found from a number of studies that the presence of an ectopic posterior pituitary really pointed towards permanence of growth hormone deficiency. Then normal or small pituitary glands, an enlarged empty cella, or pituitary hyperplasia when combined with multiple pituitary hormone deficiency were associated with mutations in transcription factors such as PIT1 or PAL1F1, PROP1, HESX1, LHX3 and LHX4, and many others. Chiari malformations were more associated with LHX3 and LHX4 abnormalities, and the finding of a very small anterior pituitary height below -2 SDS was possibly more associated with a growth hormone releasing hormone receptor defect. Remember that severe forms of growth hormone deficiency with normal pituitary glands have been reported in the literature. Against this, a diagnosis of isolated idiopathic growth hormone deficiency in the setting of a norm or slightly small anterior pituitary size with a normal pituitary stalk and a normal location of the posterior lobe is probably associated more with transient forms of growth hormone deficiency or quote unquote partial growth hormone deficiency, or you may be dealing with a patient who has a false positive diagnosis of growth hormone deficiency when those MRI findings are present. So let's now go a little bit more into the specific testing for growth hormone deficiency and discuss the pitfalls of growth hormone provocative testing. So we know that growth hormone testing should be performed in any patient who presents with a history and exam that's compatible with growth hormone deficiency, who has a low height velocity and also a low IGF-1 below -1 standard deviation. Growth hormone testing is actually essential for us to differentiate between growth hormone deficiency leading to IGF-1 deficiency or primary forms of IGF-1 deficiency due to growth hormone resistance. So it's not difficult, of course, to diagnose patients who lie at the end of the spectrum. What's been more difficult over the years is to define the threshold at which patients in the middle of the range will fall. The threshold for growth hormone deficiency has increased over the years from 5 to 7 to 10, and it remains a challenge to identify that threshold that really makes the diagnosis of a child who has more moderate forms of growth hormone deficiency. So we know there are multiple pitfalls related to growth hormone stimulation testing, and several decades of studies have not changed that viewpoint. Multiple provocative agents can be used to test for growth hormone deficiency, although growth hormone releasing hormone may not be appropriate in all children. Many insurance companies, especially in the United States, they require a documented failure to two stimuli to limit the number of false positive results that come out of this testing. We know that repeat testing is needed in certain growth hormone deficient subgroups, especially patients with quote unquote partial growth hormone deficiency diagnosed around the peripubertal period will need retesting when puberty starts, as at least 60% of these patients will retest normally upon retesting. Patients with obesity have reduced growth hormone secretion overnight, but also have reduced responses to growth hormone provocative testing. So there is really a need to have body mass index specific cutoffs for these patients, and these are not readily available. And we should keep in mind that severe hypoglycemia may occur with growth hormone stimulation testing, especially when using glucagon in very young children, and definitely when using insulin in children below 10 years of age. Additional limitations of growth hormone stimulation testing relate to assay standardization and the poor reproducibility of all these provocative tests. Newer standards that use monoclonal antibodies and isotope dilution mass spectrometry may become the way to go in the future, and they provide better reproducibility of the measurements. Many labs now perform growth hormone measurements using automated, non-radioactive chemiluminescent assays. And in the figure, you can see the results of growth hormone testing in 52 children with growth hormone sufficiency and 44 children who have growth hormone deficiency in a study reported in 2014 by a German group. And if you look at the horizontal line, it shows a growth hormone cutoff or a threshold around 7 nanograms per ml. And this threshold seems to provide the maximum rate of diagnostic accuracy of correctly classifying children with growth hormone deficiency. So using the newer assays, the chemiluminescent immunoassays, we see that growth hormone measurements are about 40% lower than those measurements obtained using immunoassay-based testing such as RIA. So the new threshold for growth hormone deficiency should be revised and lie closer to 7 nanograms per ml with a number of these newer and automated tests. What about the question, is there a need to do sex steroid hormone priming before growth hormone stimulation testing? We know that estrogens increase growth hormone secretion. On the left here, I'm showing you data from sort of a cardinal study done now a couple of decades ago, and it shows the effect of pubertal stage on peak growth hormone response. So 84 normal children were submitted to growth hormone provocative testing at different stages of puberty, Tanner stage 1 to Tanner stage 5. And the cutoff was here 7 nanograms per ml, above which these normal children should respond. And you can see that for patients in Tanner stage 1, Tanner stage 2, and Tanner stage 3, there were responses below 7 nanograms per ml. Actually, 64% of the patients in Tanner stage 1, 44% of the patients in Tanner stage 2, and 11% even in Tanner stage 3 did not reach that threshold of 7 nanograms per ml. Only in Tanner stages 4 and 5 did all normal children have a normal peak growth hormone response. So a subset of these patients were then retested during after they were exposed to 2 days of ethinyl estradiol, 2 days of estrogen exposure. And you can see each time for exercise, physiologic testing, or arginine insulin tolerance testing, or on the right for combined testing, the difference in peak response with growth hormone without priming and with priming. You can see that the peak growth hormone range goes up significantly, hereby reducing the false positive rate from 39% to 5%. Some additional information in support of hormone priming is found on this slide. Study reported by Martinez et al. This was a double-blind, placebo-controlled study that evaluated the effect of estrogens, again here estradiol, on growth hormone stimulation testing, comparing growth hormone deficient children and non-growth hormone deficient short children, which we can call ISS, idiopathic short stature patients. Here, estradiol was given for 3 days, and children were either prepubertal or early pubertal. If you look at the first and the third bar, you see the difference in patients with idiopathic short stature. In idiopathic short stature patient, the maximum growth hormone response mean value went from about 18 to about 28. So there's an increase with estrogens. But if we look at the second and the fourth bar, there was no significant stimulatory effect of estrogen in the growth hormone deficient children. So growth hormone stimulation testing based on these data after estrogen priming has a higher diagnostic efficiency. But as there are good data to support priming, there are also plenty of studies that argue against priming. Here are results of growth hormone stimulation testing using a variety of provocative agents. 10 different testing protocols were applied here. In a large number, more than 470 normal stature children or normal short children. And the mean peak growth hormone concentrations varied from 9.7 to 61.8. But if you compare the prepubertal children in the white bars, open bars, or the crossed bars, which are pubertal children, you can see that there's really no difference in the growth hormone response based on whether or not they're prepubertal or pubertal, except perhaps for arginine on the top panel in the middle, where there is a difference pubertally with a better response. So if we summarize this, if you are in the pro camp for sex steroid hormone priming prior to growth hormone provocative testing, you will say that it will improve the specificity of the test and will reduce the number of false positive diagnoses. It's a relatively safe procedure that's inexpensive, and it may be helpful in the peripubertal period, definitely in patients who have a picture consistent with constitutional delay of growth and maturation. On the other hand, if you are against priming, you will argue that there is no standardized methodology because the type of sex steroid used is different. There are practical considerations. And above all, we don't have specific cutoff limits for growth hormone peak concentrations with priming versus not priming. And it is not a physiological test, although you can argue that growth hormone stimulation testing by itself is not physiological. Probably the stronger argument that what people in the contra side will have is that it may lead to an underdiagnosis of milder or transiently growth hormone deficient patients in the peripubertal period that may benefit from growth hormone therapy. So if we look at the most recent guidelines and their recommendation with respect to sex steroid hormone priming, there are guidelines from the Pediatric Endocrine Society, the Drugs and Therapeutics Committee. They came out with a conditional recommendation a couple of years ago to do sex steroid priming prior to provocative growth hormone testing in boys older than 11 and girls older than 10. And this mainly to prevent unnecessary growth hormone treatment of children who will end up having a diagnosis of constitutional delay of growth and maturation. The specifics for priming are summarized on this slide. You can use either beta estradiol for both boys and girls for 2 days prior to the test, and for boys you can use intramuscular testosterone, for example 100 milligram a week before the test. For the last 10 minutes now, I'd like to change gears from testing and screening to a couple of issues related to the management of growth hormone deficiency. And first of all, I want to talk about titration of growth hormone dosing based on IGF-1 concentrations. To go back to the Pediatric Endocrine Society guidelines from 2016, a recommendation for the treatment of growth hormone deficiency is made to dose patients based on weight or body surface area. And there are general recommendations for dosing to use if you do body weight based dosing based on FDA approval for growth hormone therapy and growth hormone deficiency. These are the so-called standard dosing. And most pediatric endocrinologists will adhere to this. They may start with a dose in the lower range and then maybe titrate upwards based on their patient's response to treatment. There are some manufacturers who have obtained approval for higher dosing, and there's even one manufacturer who has an approval up to 0.7 milligrams per kilogram per week for pubertal dosing, although I do not know a lot of people who will adhere to that treatment approach. But there is a strong rationale for dosing growth hormone based on IGF-1 concentrations. It is based on two principles. First of all, we have all seen and observed that there is a large inter-individual variation in growth response to the same per kilogram body weight dose of growth hormone. We've all seen patients who we've diagnosed with moderate forms of growth hormone deficiency, who we treat with similar doses of growth hormone, and dosing is done based on body weight. And then we look at the response, and it can be quite different. The second principle supporting a rationale for IGF-1 based dosing is the fact that the growth effects of growth hormone are due in large part to the induction of serum IGF-1, and serum IGF-1 concentration can therefore serve as a biomarker of growth hormone action. Most of the data in support of IGF-1 based titration come from particular studies, and I'm going to review these in a little bit more detail for you. There's a 2-year multi-center open label trial that treated patients with growth hormone that were prepubertal, they were short, and they had low IGF-1 concentrations. 2 subgroups of patients were identified based on their peak growth hormone concentration. Either patients were growth hormone deficient and had a peak growth hormone concentration below 7 nanograms per ml, or patients were short but growth hormone sufficient with growth hormone peaks above 7 nanograms per ml. Then these patients, and we will focus predominantly on the growth hormone deficient patients, they were randomized to one of 3 treatment groups. Some patients were treated conventionally, weight-based growth hormone dosing with a dose of 40 micrograms of growth hormone per kilogram per day. And the 2 other groups were approached differently. One group was dosed to titrate the IGF-1 concentration to the mean, an IGF-1 SDS of 0. And then the third group was dosed with growth hormone to achieve IGF-1 concentrations in the upper quartile with a target for IGF-1 at +2 standard deviations. Let's look at the results. The upper figure, figure A, shows you that target IGF-1 values were reached within 6 to 9 months. As a matter of fact, within the first month, there was a significant increase in IGF-1 concentrations. So this is feasible. You can reach your target IGF-1 concentration, whether it's the mean or +2 SD, fairly easily and in a relatively short period of time. If we look at the delta height SDS for the 3 treatment approaches on the bottom in figure B, growth hormone deficient children who were titrated to an IGF-1 of +2 SDs experienced a statistically significant greater delta height SDS versus the growth hormone children titrated towards the mean IGF-1 or 0 SD. With the +2 group, the delta height SDS was +2. The ones titrated towards the mean, the delta height SDS was +1.4, and this was still better than for the conventionally dosed group, where the delta height SDS was +1.2. So 65% of those who were titrated towards an IGF-1 of +2 had a delta height greater than 1.2 standard deviations. And then only 21% of the patients that were titrated towards an IGF-1 of the mean had such a delta height SDS greater than 1.2. So there's that difference. However, no matter what your treatment approach was, it was noted that patients with lower peak stimulated growth hormone concentrations had a better response, and that was true for either treatment approach. Obviously, the better delta height here over 2 years for the group titrated towards an IGF-1 of +2. Now, if we look at the doses of growth hormone that were required, we see that in the growth hormone deficient patients, look at the white bars of these 2 figures, that the average growth hormone dose to achieve an IGF-1 close to the mean was 37 micrograms per kilogram per day, whereas the average growth hormone dose needed to achieve an IGF-1 of +2 SDS was 91 micrograms per kilogram per day. So a big dose difference. And note the spread in growth hormone doses required for each therapeutic target. There is a wide range of growth hormone doses, which indicates that there may be some underlying difference in growth hormone sensitivity that could be due to polymorphisms of the growth hormone receptor and the peptides involved in the post-growth hormone receptor signaling pathway. Then the question was also raised, okay, we can get a better response with titration of growth hormone towards, with an IGF-1 titrated towards +2. But is that really better in the long term? And what are the disadvantages, first of all, from a safety perspective, but also from a cost-benefit perspective? And if we look at the table and the figure, we see a cost-benefit analysis based on a calculation of a delta height SDS per or over the growth hormone dose. And if you look at this ratio as a parameter for cost efficiency, the highest value is found in the patients who were titrated towards an IGF-1 of 0, towards the mean. So a dosing strategy based on IGF-1 targets can potentially be more cost beneficial using this approach. And so targeting IGF-1 as towards the mean was not only leading to a better cost benefit than if you compare it with weight-based dosing, it also resulted in a lower proportion of IGF-1 values above +2 SD than with the conventional weight-based dosing approach. So if we put this all together, we probably still should do individual adjustments first based on oxology, based on our patient's treatment response. But measurement of IGF-1 should definitely be considered to monitor compliance. And in addition to this, measurements of IGF-1 early on in treatment and throughout growth hormone therapy may also provide information on the response to growth hormone therapy. And especially in the first year, it may provide information on the response to growth hormone therapy sooner than changes in height velocity would indicate so. And we've seen that some trials using IGF-1 based growth hormone dosing suggest that this may optimize therapy in growth hormone deficiency while allowing for the use of smaller growth hormone doses. From these studies, it's noted that about 20% growth hormone dose adjustment usually will lead to a 1 standard deviation change in IGF-1 in growth hormone deficient patients. This being said, studies on adult height comparing the effectiveness of IGF-1 based dosing with standard weight-based dosing have not yet been done, and there are very few data on the safety of titration of growth hormone dosing based on titration towards an IGF-1 of +2 or in the upper quartile. So to end with, I'm going to say a couple of words about the management of growth hormone deficient patients who demonstrate an inadequate response to growth hormone therapy. If we go back to that patient that I showed in the beginning of the presentation, this is an individual who eventually was diagnosed with growth hormone deficiency, who shows a very gradual, sort of subtle deflection from his target height percentile, which is around the 25th percentile, around 2 to 3 years of age, to where he is now at 8 years of age, below the 5th percentile. By 8 years of age, he has developed a bone age delay that's about 2.5 years, and his baseline IGF-1 was 68 nanograms per ml. The patient underwent arginine clonidine growth hormone stimulation testing, and he reached a peak of 8.1 nanograms per ml with this testing. The patient was diagnosed as having some degree of growth hormone deficiency, and he was started on growth hormone therapy at a dose of about 0.26 milligrams per kilogram per week. And you see here with the red dots his treatment response in the first 18 months of therapy. He had repeat IGF-1 concentrations measured, and they were 112 and 129, and compare that to the range for this particular lab and for his age on top of the slide. So he had a suboptimal response, and he had a somewhat lukewarm increase in his IGF-1 with this dosing. So a question can be raised, do his low IGF-1 value indicate poor adherence? Is there inadequate storage? of the growth hormone by the parents, or is there any other condition we need to consider, any co-therapy perhaps that affects growth response? We know that growth hormone therapy in children with growth hormone deficiency is quite effective. These are data from the National Collaborative Growth Study, and you can see by looking at the growth velocity or height velocity change from baseline over many treatment years, and the delta and the height SD scores over many years, that patients continue to respond well even after an initial strong catch-up growth. Other large post-marketing surveillance databases such as KIGS, the Kabi International Growth Study, have shown that near adult height for patients with growth hormone deficiency is close to -0.8 standard deviations. So these patients started off of a mean height SD of -2.4 to -2.5 at the beginning of treatment. Most patients end up in the normal range with a near adult height of -0.8. And there's no difference whether your patient has isolated idiopathic growth hormone deficiency or growth hormone deficiency on the background of multiple pituitary hormone deficiency. But note the differences in responsiveness and the wide range of near adult height values. And note that there's quite a big group of patients, a large group of patients that has what we should call a suboptimal outcome. So what could be the reasons for this variability in growth hormone response? Well, first of all, of course, poor compliance and subnormal treatment adherence. As one of our prior Surgeon Generals stated, growth hormone therapy fits with this. It won't work if the patient is not getting his or her injections. You see some nice data from a study from Wayne Cutfield's group that looked at height velocity over a period of 6 to 8 months. And it's plotted out here in function of the degree of compliance. High compliance, good growth response; medium, low compliance, less good growth response. This is very obvious. There are other reasons that could be related to an incorrect diagnosis, for example. There may be a comorbidity which was not picked up. The patient may have developed hypothyroidism. There may be a co-therapy that could affect growth. If a patient's protein intake and nutrition is suboptimal, the response to growth hormone therapy may not be there. We are all familiar with the fact that younger patients respond better. If we're dealing with growth hormone deficiency with patients who have pubertal changes, we really need to interpret the response in function of their Tanner stage. There may be a discordance in the bone age maturation with the degree of growth hormone deficiency, for example, because of coexisting obesity, and there may be a degree of growth hormone resistance or insensitivity at play here. Poor response to growth hormone therapy in children with growth hormone deficiency is not that uncommon. Here are data in more than 450 Scandinavian patients reported by Peter Pang. Patients had different forms of growth hormone deficiency. It was either isolated, idiopathic, or was organic growth hormone deficiency, or patients had been diagnosed with growth hormone deficiency on the background of a history of smallness of gestational age. Overall, 30% of growth hormone deficient children in this cohort had a delta height in year 1 that was below 0.5 standard deviations. And you can see different modalities there of defining a poor response, and depending on the definition of poor response that was used, poor responders varied anywhere between 13 and 36%. And many children that respond poorly to growth hormone therapy are not just patients with mild degrees of growth hormone deficiency. Even in the patients who have more severe forms of growth hormone deficiency, it was found that there were a number of poor responders. Going back to data from the Kabi International Growth Study here for a large cohort of children who have idiopathic isolated growth hormone deficiency, On the x-axis, you see first year delta height, and on the y-axis, you see the height outcome after treatment is completed, the total delta height. And you can see the very strong correlation that there exists between the first year response and the adult height achieved. And this is very important when we start patients on growth hormone therapy for growth hormone deficiency. Determination of a poor response to growth hormone in children with growth hormone deficiency should occur in the first treatment year. You can use one of several criteria. You can use change in height SDS less than plus 0.5, or an increase in height velocity less than 3 centimeters per year. Many of us will take this second approach. We will measure patient with a certain interval in between, and we will then calculate an annualized height velocity and then plot it on one of the height velocity curves, as you can see on the lower left here. Now, it's easy to imagine that one can easily make an error in the calculation of the true height velocity. We can overestimate it easily if we extrapolate. We can also underestimate it. So perhaps it's better for the clinician to interpret the individual patient's response to growth hormone therapy based on population-based data. And on the right, I show you data for height velocity for thousands of male, 8,442 males in this situation with isolated idiopathic growth hormone deficiency during the first year of the National Collaborative Growth Study. These data exist also for females. They exist also for patients with idiopathic short stature, for patients with organic forms of growth hormone deficiency, and for Turner patients. But what this gives us is there is an ability here, based on these large data points, to develop these response curves. There's a mean height velocity response curve for this large population, and a mean height velocity +1 and -1 standard deviation. And so here, you not only compare your patients with the response based on the age of the patient and the sex or gender, but also specifically the response for the same diagnosis that you're treating your patients for. So what was found from these studies is that if the mean height velocity was, or if the height velocity is equal to the mean -2 standard deviations, I should say, that seems to correspond more or less to the pretreatment height velocity. It's not any better than the pretreatment height velocity for many years, especially in the childhood age range. And if the mean height velocity -1 standard deviation is looked at, that may be more consistent with an acceptable or an adequate response. So for example, based on these response curves that were created based on this population model, you can look at patient number 1 as clearly having a poor response at age 5. Patient 2 is 7 years old, and he clearly has a good response because his mean height velocity for this diagnosis of growth hormone deficiency at this age, is at the mean +1 standard deviation. The height velocity for patient 3 is probably borderline, and then patient 4, who is almost 12, has an acceptable height velocity because the height velocity of that patient is close to the mean for this population of patients with the same diagnosis. So this can be very helpful and is somewhat more reliable to interpret your patient's growth response. So in conclusion, if we try to put this all together, how can we manage patients who demonstrate a poor response to growth hormone therapy after we start them at a dose of growth hormone specific for growth hormone deficiency? And we've measured baseline IGF-1 concentrations. Somewhere between 3 and 6 months of follow-up, we need to assess the response first by determining an interval height velocity and also measuring the IGF-1 concentration. And if the growth response is unsatisfactory, we should verify the growth hormone dosage, check compliance and treatment adherence, and question whether or not there is underlying pathology that has not been diagnosed. This approach will allow us to address those patients who may have some resistance to growth hormone, whose sensitivity to the growth hormone dose used may not be there. And it may allow us to titrate the growth hormone dose based on the IGF-1 concentration measured. And this approach can be repeated another 4 to 6 months later. Somewhere at 9 to 12 months of age, we assess the growth response again. And if it remains unsatisfactory, we can adjust the growth hormone dose again if there's no safety issues, if there's still room to titrate the growth hormone dose based on the measured IGF-1 concentration. At this time, we still need to ask for compliance issues, and we may have to consider, depending on the growth hormone dose we are already using, change to an alternative therapy such as recombinant human IGF-1, or perhaps this patient should be stopped with growth hormone therapy. And these issues should be addressed very early on in treatment, actually before the patient is started on growth hormone therapy. Such a discussion needs to be held with the parents and the patient. So in conclusion, I have some closing thoughts. We have seen that growth hormone secretion exists in a continuum and that there are varying degrees of growth hormone deficiency. Because of this, separating milder growth hormone deficient children from growth hormone sufficient short children has remained a challenge for pediatric endocrinologists. The diagnosis of growth hormone deficiency should be based on a history, a carefully obtained review of systems, a well-performed exam. It should be based on oxology, biochemical data, neuroradiological data, and growth hormone provocation testing. And I should add should also be based on genetic testing if available and for specific situations. Cutoff values for peak growth hormone concentrations during growth hormone provocative testing are arbitrary, but recent studies suggest that a cutoff of 7 nanograms per ml is accurate. Growth hormone dosing should be done based on oxology. We should start growth hormone therapy with a lower dose range, and then we can do upwards titration based on the treatment response. IGF-1 titration, and I should stress towards a mean, may be superior than fixed growth hormone dosing based on body weight, whereas titration of IGF-1 into the upper quartile range provides a more robust response, but with very few safety data. And most people do not recommend this approach. Although there's no overall agreement on how to define a poor response to growth hormone therapy, it is essential to not only appreciate that a poor response is possible, even if we are comfortable with the diagnosis of growth hormone therapy, and it is essential to identify a suboptimal response to growth hormone therapy early on, i.e. in the first year of therapy, and then to reassess the growth hormone diagnosis and the ongoing therapy we are prescribing. So thank you very much. And I think we are ready to take some questions, which I know there are.
Thank you, Philippe, for a superb lecture. We have lots of questions, but let me kick off by pushing you a little bit. So I think you made a point quite appropriately of being very balanced in your perspective on many of the controversial issues. But let me push you and ask you, given the data that you show, what is your personal approach to the question of sex steroid priming and the cutoff limit for defining growth hormone deficiency? What do you do in your practice? What do you recommend?
All right, so I'd like to first make, in response to that, a general statement. For me, a growth hormone stimulation test is not an all or nothing. I use it as a piece of information in the diagnostic evaluation. And I will have, I need to be convinced by the history and the physical exam, and especially the growth pattern, before I order the growth hormone stimulation test. So I would say I have a relatively high threshold for growth hormone provocative testing. Once decided upon that, the we do in our center growth hormone measurements using an assay based on chemiluminescence. So we provide the results based on that assay methodology, and my cutoff would be 7 nanograms per ml. But we also still convert it to the equivalent value that would have been obtained if an RIA was done, because we have to use that information since the insurance companies in the United States still base their decision-making process on that information. With regards to steroid priming, I tend to be in the camp of doing this for selected patients. There's no question that for patients who seem to have a presentation that is consistent with constitutional delay of growth and maturation, that I will prime these patients. It becomes a little bit more tricky when you go lower into the peripubertal age range, that i.e. 9 years of age, 9 to 10. And sometimes I see patients who have a deceleration in growth that is a little more than what I would have expected based on the expected normal physiologic dip at that time. And I think those may be good candidates to also do priming on, which would mean patients a little younger than the current guidelines recommend, because sometimes it's not always easy to discern if there are other interfering factors for that child's growth pattern at that time.
So let me weigh in and say, I also believe that there's a very strong rationale for sex steroid priming. I think the data that you showed from the NIH study many years ago and subsequent studies are very convincing that we way overdiagnose GHD in short children when we don't sex steroid prime. I personally don't find the recommendation from the Pediatric Endocrine Society about sex steroid priming convincing. I don't understand why it should not be done in younger children. I've all my career done sex steroid priming in all age groups. I've never had any untoward consequence of doing it in 2, 3, 4, 6-year-old children. In fact, one might argue that that's the age group in which sex steroid priming is most useful. But I don't want to belabor that point because you have so many other questions. One question, Philippe, is the use of IGF-1 measurements in children who are cancer survivors, where often there's fairly convincing evidence that the patients are growth hormone deficient, and yet the IGF-1 levels aren't invariably low. What do you have any special recommendations for assessment of cancer survivors?
So yes, I think it's a good question. I find that some of these patients can be quite difficult to ascertain biochemically, and I agree with the point that IGF-1 concentrations may not be that low. I think it's in part related to the fact that growth hormone deficiency is a very gradual process in these patients, and I would have a lower threshold in these patients to do repeat IGF-1 levels, maybe supplemented with some of the other screening tests, and probably have a lower threshold to do stimulation testing in these patients.
Philippe, Brenda Cohn writes in a question that I would have asked myself, which is, do you really believe that there is such an entity as transient, idiopathic, isolated growth hormone deficiency, or are we just really identifying some children who are in a constitutional delay, idiopathic, short stature group in whom we have overdiagnosed GHD?
Yeah, I think I'm in the camp of the latter group, but there are always patients that puzzle me. And, sometimes background information is limited. There may not be a family history of constitutional delay. Sometimes there are interfering factors such as the use of medications for attention deficit hyperactivity disorder. Sometimes there are nutritional issues that really make it harder to interpret the growth pattern that these patients demonstrate between the time that they are allowed to undergo a physiologic dip. And I agree that a lot of these patients who are then tested for growth hormone deficiency are found to have poor peak responses. If you retest them, the majority of those will test normal. So I'm very, very careful and approach them conservatively. That being said, there are patients who exceed that dip in growth velocity around that time. That's one of the reasons I use priming. We have no other information available to make a more accurate diagnosis. If you look, for example, at overnight sampling, people have looked to see if that adds anything, and there's a great discrepancy with the results of growth hormone stimulation testing and what you find on overnight growth hormone secretion. Many patients, more than half that you test abnormally, will have normal growth hormone secretion, or you fail to pick that up with overnight sampling. So we're really limited by the type of testing that's available and the lack of reproducibility. So, forming a total picture is most important. But I agree that the majority of these patients labeled as having quote unquote transient growth hormone deficiency probably are normal and are a result of our limitations in testing, but there's always exceptions.
Another question about sex steroid priming was asked: why not ethinyl estradiol? What do you perceive as a problem with ethinyl estradiol?
Why not what?
To use ethinyl estradiol.
You can. I think you
Because
can.
your slide said not to use it.
No, I think you can both. You can use estradiol, you can use ethinyl estradiol. Plenty of studies were done with that. And I think in Europe, for example, there's those people who are adherents, those colleagues who are adherents to priming, they use ethinyl estradiol without hesitation.
I agree. I've not ever seen a problem with ethinyl estradiol.
No.
Philippe, several people, Harry Hirsch and others, have asked about the use of BP3 measurements that you alluded to. And two questions related to that. One is the potential use in identifying patients with ALS defects. And secondly, do you think there's any value in looking at IGF-1 BP3 ratios or some measure of, quote, free or bioactive IGF?
Yeah, with regards to the latter, the problem there, it's very difficult to measure free IGF-1 accurately. Few labs around the world have demonstrated ability to accurately measure free IGF-1 concentration. So I think clinically, this is not something that's available to most of us. There is some value in looking at ratios between binding proteins, BP3 IGF-1, as well as IGF-BP2, IGF-1, to which I alluded to, and it may improve some of the sensitivity of diagnosing growth hormone deficiency. I agree, and there are some good papers out there that demonstrate this.
Several people have asked, Philippe, is there a maximum growth hormone dosage that you are unwilling to exceed? And would you ever consider the combination of growth hormone plus IGF-1?
So that's a good question. So first of all, I feel even though I tend to belong to the camp that feels uncomfortable titrating patients to an IGF-1 of +2 because of the limited safety data that we have. That being said, there are these patients who are, and these may not necessarily be growth hormone deficient patients. These may be more patients who have sort of an idiopathic form of short stature. And there are patients in whom I have titrated IGF-1 in the upper quartile and around +2, perhaps even slightly above. And I would say that I would tolerate that if I see a treatment response. I would feel uncomfortable to treat somebody from age 8 to age 16 with IGF-1 levels at +3. But if somebody can have catch-up growth for a relatively short period of time with an IGF-1 level at +2, I would not necessarily feel that is unwarranted. And for example, classic patients in whom the growth hormone doses may be higher are patients with Russell-Silver syndrome, for example, patients who may have resistance at the level of the IGF-1 receptor. I will tolerate higher concentrations of IGF-1, and therefore I need to go up to higher doses. This, however, is uncommon in our classic growth hormone deficient patients that I treat. With regards to the combination treatment, as you know, there was one study that was done, a 3-year trial where combination therapy with growth hormone and IGF-1 showed rather nice responses with a higher delta height SDS in the first year with combination therapy in patients who had milder degrees of IGF-1 deficiency. The improved responses were not necessarily noticed as much in the second and third year. The overall result was still that combination therapy led to a better delta height SD. So again, I think if we specifically look at the patients that were to be discussed today, growth hormone deficient patients, there may be a role for combined treatment in selective patients who may have some growth hormone resistance. Also, the combination therapy approach may be more suited for patients who don't necessarily have growth hormone deficiency, but just have idiopathic short stature, and we just don't know yet what the underlying problem is and what the degree of resistance or insensitivity is.
Philippe, in that regard, let me make a statement and ask for your response to it. So the argument would be that a child with true growth hormone deficiency should always have a robust response to growth hormone therapy during the first year. And that if you do not see it on conventional growth hormone dosage, you should always consider either compliance issues, misdiagnosis, or the possibility of growth hormone insensitivity. Would you agree with that?
I agree. As I summarized in my slide, these things need to come up from the beginning of treatment and need to be readdressed at regular intervals. I would recommend follow-up in the first year of treatment of at least every 4 months. So you see the patient 3 times, and so you can address this. There are, even if you address this, still patients where you can check off all the things, everything seems to be okay, that show a poor response. And there are patients who have sort of a combination of suboptimal growth hormone secretion and suboptimal action. And I think the approach that I tried to summarize allows for the identification of these patients and allows for an adjustment of the growth hormone dose, safety issues taking into consideration, to be adjusted. Because if everything else is ruled out and the growth hormone response is still not there, I think it is appropriate to adjust the growth hormone dose because you want to see an in vivo effect. So I'd be less worried about creating a sort of an unsafe situation for the patient if the growth response, which is the true in vivo outcome we're looking for, is also not there. So you have to wonder, if you don't have a response from a growth perspective, will you then cause adverse effects because you go up on your growth hormone dose?
Very good. What about the use of therapies to delay puberty in combination with growth hormone? What is your take on that?
So I think there are some data that show that a variety of drugs, such as aromatase inhibitors, can be helpful in certain situations. This is still off-label in the United States. If you look at GnRH analogs, which have been available for puberty modulation for a longer period of time, I think unless you look at specific patient situations, for the classic growth hormone deficient patient, the use of GnRH analogs, I tend not to adhere to that, because the height that you can gain, the height benefit you gain from slowing down puberty around 11, 12 years of age is minimal to non-existing, I think. Data from precocious puberty studies show that if you commence a GnRH analog therapy beyond 7, 8 years of age in patients who have precocious puberty with bone age advancement, the height gain from that is minimal. Aromatase inhibition, I tend to reserve to those patients who have discrepant bone age maturation for their degree of presumed growth hormone deficiency and who are diagnosed relatively late. I think that can be beneficial for certain patients.
Philippe, one final question, please. How often, on a newly diagnosed patient with GHD in whom you have started therapy, how often do you recommend seeing the patient? How often do you recommend measuring IGF-1? And how often do you recommend getting follow-up bone age films?
So if we talk about the growth hormone deficient population, in the ideal world, I think you see a patient again after 4 months. If you go earlier than 4 months, I guess 3 months would be acceptable, it becomes harder to assess the growth response and height velocity accurately. And I think and then you see him again perhaps at 8 months and then at 1 year, because I think the evaluation of the patient in the first year is crucial. And I think at those times you can measure IGF-1 concentrations and make adjustments to the growth hormone dose if you think that's necessary. How often do I do bone age measurement? I tend to get bone age assessment about once a year. I'm especially interested in patients who are treated with relatively higher doses for the indication of growth hormone deficiency, or patients who have coexisting obesity or overweight, or may have comorbidities that could affect bone maturation. So tend not to do that more often unless there's other disorders that could accelerate bone maturation, perhaps early puberty.
So Philippe, thank you for a superb lecture, exactly what we would have expected from you. Please, anybody who has additional questions, please feel free to email Dr. Bacliao. I'm sure he would be happy to answer that. This is the final of the 6 lectures in the growth hormone series. Please feel free to check the Human Growth Foundation website and exhibit hall for announcements of other webinars. There is an outstanding series on bone pathology that will be available to all of you. So again, I'd like to thank Philippe and all of our other lecturers as well as the Human Growth Foundation for their sponsorship of this. Everybody have a good day.